Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello, and welcome everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Jaimie Anderson is a paid University of South Florida employee, presenter, and affiliate for MedBridge. As a guest on this podcast, Jaimie receives an honorarium from SpeechTherapyPD.com. She has no relevant non-financial relationships to disclose. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. I'm also adjunct faculty for both James Madison University and Old Dominion University. And as the host of Brainstorms, Functional Neuro Rehab for SLPs, I do receive financial reimbursement from SpeechTherapyPD.com for this and other webinars. Now, without further ado, we welcome our guest, Jaimie Anderson, MS, CCC-SLP, BC-ANCDS. Jaimie Anderson is a medical speech-language pathologist, or SLP, board certified by the Academy of Neurologic Communication Disorders and Sciences, BC-ANCDS. She currently evaluates and treats complex multi-phase swallowing, voice, upper airway, and motor speech disorders in a multidisciplinary team at the University of South Florida Joy McCann Culverhouse Center for Swallowing Disorders in Tampa, Florida. She earned a Master of Science at Florida State University. Clinical experience includes University of Texas MD Anderson Cancer Center, Cleveland Clinic, Florida, and Memorial Regional Hospital. She serves on committees for the ANCDS, Dysphagia Research Society, and ASHA Special Interest Group 2, which is the Neurogenic Communication Disorders Special Interest Group. Welcome, Jaimie. Thank you so much for being here.
Thank you for having me.
Of course. This is a fun topic, and I think still sort of new research and, kind of a new terminology that we're using now for functional dysphagia. So I'm really excited about this, and hopefully you are too. So we'll get to talk about all this cool stuff. Before we kind of start with the questions, I did want to kind of have you give kind of a definition, if you will, of what functional dysphagia is.
Ooh, that sounds like a really easy question.
I know it's not.
It's not. So that's a great way to start. It depends on who you ask. So functional dysphagia has a specific diagnosis definition from the Rome Foundation. So the Rome Foundation is a group of gastroenterologists. So if you're asking that group, it is a diagnosis of exclusion. So somebody feels like food is getting stuck. Specifically, they describe in their esophagus, although there are articles that describe that you can say it for the oropharynx as well. And when they look at motility tests, it's negative when they do an EGD or endoscopy and they, take biopsies. There's no EOE or what's called eosinophilic esophagitis. When they do a barium swallow sonogram, not by speech pathology, there's no motility, no strictures, no structural problems. And so then they call it functional dysphagia. So it's really from that group specifically, it's a diagnosis of exclusion.
Okay.
But if we want to go into the other groups, then we can go into those. But
yeah, I think that's a great place to start. And again, we, as practicing medical SLPs, I think a ton of us see this all the time. And particularly when I was still working in the acute care hospital, but was getting those 1-time or 2-time outpatient modified barium swallow folks who weren't on my caseload, but they were coming from an outside source to me to do the imaging. And I would look at them and be like, there's literally nothing going on. But then they're in there, they're the ones who hang out after the test is over with 18 million questions because there's something going on and they don't know how to necessarily articulate every symptom, because a lot of times it's more than one thing, not just one single solitary symptom. But how did you get into functional dysphagia? Because I know you have a strong language background as well, as far as, it's no easy task to be board certified by the ANCDS. So that's pretty impressive.
Thank you. I do love the group. I definitely encourage anybody that's into neurogenic communication disorders to look into it. It's a really hard process, but Renee and who was on the podcast with you before that talked about functional speech disorders, she's board certified, and I know her through that. So that's an aside, but a really great group of people. So board certification in ANCDS happened while I was at MD Anderson, really was focusing on brain tumors. And in 2021, I started at the USF Swallowing Center. And that's when I had a similar experience to you, Renee, about here I am in an outpatient swallowing center, completely expecting the most complex, severe swallowing problems. And we see that, the late radiation associated dysphagia, our patients with ALS and other motor neuron diseases. And though we do see that, I was really taken aback by those patients that you're describing. And that's really, like, for my definition of functional dysphagia, is those patients that are coming to you and this is their second, third, fourth opinion. And, they get these modified barium swallow studies and they are maybe on a peg tube, maybe on a liquid diet only, or just avoiding a lot of, normal foods. They're on a pureed diet. They're 25 years old and a cop, but they don't eat anything above a pureed food. And they have no, structural or, neurogenic reason for what they're describing as a swallowing problem. And, you do the swallow study and you're like, well, wait, your patient reported outcomes are so high and your swallow study is normal. And what am I supposed to do? Just like, you're normal. Good luck. Be the fourth SLP that says, well, we did the MBS, you're not aspirating. And so I think, so that's how I got into it, is that being at the Swallowing Center since 2021, I started seeing more and more of these patients. And I looked at my colleague, Joy Gaziano, who really, she's been doing this type of work for 30 years, learned so much from her. And in the past 3 years, I've just dug really deep into it to try to understand it better, because prior to being there, the only thing I'd ever heard of is kind of muscle tension dysphagia, which I think is a really great term, but it doesn't, and a great diagnosis, but it doesn't explain all of these patients. And so that's how I got into it, is, through the thick of it, seeing these patients day to day.
Yeah. Well, and I think that a lot of times that's how we kind of grow and learn in our practice, right? We're thrown a curveball, and then we have this responsibility to learn more about it, or refer, or if we have the ability, like, when you work somewhere with expert SLPs or subject matter expert people, board certified people, you have that opportunity to have a mentor and learn something more. So I think that's a great point to make too.
I absolutely, I just want to jump on that too, because I think so often we go, well, that's not my expertise, or I don't work with that, so somebody else will have to do it. And I think There are times where that can be appropriate or that is appropriate, but often nobody's taking a chance on these people, and this isn't many people's expertise. And that, I think if, you just don't go in blindly, but exactly, you look to the left, look to the right, go on to, listen to podcasts like this, look at your continuing education and try to figure it out, reach out. I've had one-on-one calls about this topic more than I can count, and I'm so glad because I can't be in Virginia, right? And, all of us are very capable.
Yeah, I certainly agree with that because I know the first couple of times, particularly when I had moved solely to the outpatient clinic, that I had a couple patients exactly like this who would come in, and 9 times out of 10, they were experiencing voicing issues. A lot of times had comorbidities of GERD or some sort of reflux that they were complaining about.
Yeah.
They had all these pieces and parts that, like you said, when we did the imaging, it didn't really amount to much on the imaging, but their symptoms were impacting their quality of life. And it ranged in age from early 20s all the way up to like 80. So it wasn't
Yeah.
something, that we could follow a pattern with, like for cancer, or a pattern for people who are at high risk for stroke or cardiovascular disease or something along those lines. It's always like a puzzle. You're trying to figure out this puzzle and trying to figure out that diagnosis because, again, like you mentioned, a lot of the times by the time they got to me, they had been either in the hospital or been to the emergency department or been to their PCP, gone to an ENT,
Yes.
gone to a GI specialist, and so they've run the gamut at this point. And I'm sort of like, I felt like I was the last man standing or the last hope.
Absolutely.
Yeah,
I think, yeah, go ahead.
No, if you go ahead, I'll
Yeah.
ramble.
No. I mean, I wanted to just second that that's exactly the experience that I have had. And I think that's exactly why I want to encourage anybody to give it a try, when you are suspecting this and, just really think through it and problem solve and see what they've gone through. But if you, are yet again another speech pathologist that says, well, maybe go get it ruled out by gastroenterology, maybe go get it ruled by neuro, if you have a good argument for it, absolutely, and that's one of the big pieces that I'll argue is our diagnosis for exclusion that I kind of referred to with GI, we play a role of that too. So of course, like I'm still doing a really thorough cranial nerve exam. I'm asking them about any sort of neuro symptoms so that way I'm trying to paint a picture to say, oh, is this something that's slowly, developing and is actually going to be a motor neuron disease that hasn't been diagnosed? Oh, yes, I can argue that because they have a mild dysphonia, a little bit of hoarseness. They have fasciculations on their tongue that nobody has seen before. And they've got this oral phase dysphagia. Boom, like, yeah, let's go send it that way. But if you are looking and the cranial nerve exam is completely normal, they're 8-10, their patient reported outcomes are 36, 38 out of 40. They've had all of this work and they're fitting, and there's an inclusionary diagnosis or inclusionary criteria. If they're fitting the bill for what you are suspecting as a functional dysphagia, then I think it can be so important to try and help these patients and not just punt them off to another referral where they're just going in circle over and over and over again.
Yeah, and for me, I think the people that I would get referrals for were people that came directly from their PCP. And I think it was like they just didn't know what else to do with them. Go see speech. That girl downstairs does something with swallowing, just go see her. And so sometimes it did warrant further workup because of something like a dysphonia or
Right.
chronic cough we see a lot, and what's the cause of that? And then that kind of jumps me into how do we diagnose the functional dysphagia? Because I'm glad you mentioned the 8-10 because that was
Yes.
one of my favorites, just because the length of time you have in outpatient, if it's 40-45 minutes, you don't always have time to get through all these other things. And so that was a nice way to sort of calculate the things that they had already said and be able to have them rate it on their own. So I like that you also are a fan. Plus it's also free.
Yeah, absolutely. I do love a good free resource. So on two things that I think you've said that I think are really interesting. One is talking about the chronic cough, muscle tension, dysphonia, muscle tension dysphagia. And that's when I really absolutely say, go look at Christina Kahn's work. She, since 2016 they've written a couple of articles, and there's been some other ones too, but I really put that under that kind of irritable larynx syndrome category. And I've absolutely had those patients where I'm like, okay, you have chronic cough, you have inducible laryngeal obstruction, you have muscle tension dysphagia, muscle tension dysphonia. It's just all under that umbrella. And that's the whole argument for muscle tension dysphagia is, this is a functional dysphagia with an underlying muscle issue, like throat issue. But I've had these patients sort of kind of go on to like just the bigger umbrella term of functional dysphagia that may or may not have that muscle tension component. How do you diagnose this, or how do you find it? I referenced earlier GI and exclusion, right? So I think I really always talk about with functional dysphagia, it's one of exclusion and one of inclusion. That's very different than most other functional disorders, because if you listen again, I keep talking about Renee's podcast, but there's so much similarities. You can diagnose based off of inclusion without a lot of the exclusionary components. With functional dysphagia, both are required. So let's, again, the case that you've had so many times before, Renee, where you see these patients, they've had all these tests, everything's negative so far. Well, what is it about the case that makes it a functional dysphagia based off of like what you actually are seeing? What are the positive criteria? And so one is that EAT-10, or some sort of patient reported outcome, something that really captures, and it's great to have the quantity or data behind it, but patient reports a significant impact on their quality of life. Or like you can either use the FOIS as a way, of the functional oral intake scale that's also free, just a way of 1 to 7. What kind of diet restriction are they on? So they're on a significant diet restriction. Their EAT-10 is 36 out of 40. They feel like they can't eat or drink anything, but you do the MBS and it's normal. So that's criteria number one. It's inconsistent. Your exam is inconsistent with your report. Criteria number 2 is it's internally inconsistent. So these are the patients that say, I can eat steak one day, but I can't eat steak the next day, right?
Mm-hmm.
Or sometimes I can get pills down totally fine, but other times they just get stuck in my mouth. Suggestibility, you talk about it, if they really think about it, and that's kind of like in the hypervigilance world, then they may have worsening symptoms, versus if they're really distracted, they have less symptoms. So that internally consistent is the second one. And then the last one is those inefficient movements, or so those are, and that's where you really, as a speech pathologist, you're going, I'm a behavioral therapist, what can I do about this? Those are the ones where they're swishing the liquid in their mouth for 30, 45 seconds before they swallow. They're jutting their jaw out, to kind of get a swallow going. They're swallowing with excess effort, excess tension to squeeze it down. Their shoulders are all the way up to their ears. And so no, the epiglottis is inverting fine, the pharyngeal constriction is fine, but you can see sometimes like that hyolaryngeal excursion, that hyoid is right underneath their chin and it stays there. They never let it go. So you could really diagnose this off of those 3 things, and that's the inclusionary part. So if they're meeting all of those criteria, maybe you can even like address some of those things while they're even being worked up. But for some of the other like exclusionary pieces, because that's the other thing, if you say wait until they check every single box, it might be a little bit like you're never going to see them, because we know how long it takes for everything to happen in medicine sometimes.
Yeah. And my personal favorite is the head throwback.
Especially
when it comes to the pills, it's like, oh, everybody, this is how I take my pills. And I think the interesting part of what you said, if you sort of the suggestibility, a lot of times what I would do based on the case history was not do like a traditional, in acute care, we go in and we're like, they failed their yell swallow protocol with the nurse, and they come in and, they're already drinking and eating and doing whatever because somebody brought them a biscuit for breakfast. Right. And, it's got a tough piece of country ham where I live, and they're chugging back a Diet Coke or whatever, because that cancels each other out, the salty ham and the Diet Coke. And so, but what I would see is that if an outpatient, if I went in with a standard here's your water, take a sip, now take another sip, now take some sips back to back. Here's a straw, let's try it that way. If I did that, it seemed like they had more trouble than if I had water just sitting there and they said, oh, is that for me? And you're like, absolutely. And you don't really suggest anything, then you don't,
Yep.
it doesn't always follow a pattern. And I think that's a really important distinction to make.
Yeah.
And again, I've had that happen from a 20-year-old up to probably an 80-year-old. And it is so interesting because they have all these other little snippets in their life of things that they think are interrelated. If they're cognitively intact, they're putting all these things together going, is this what's causing this? Is this what's causing it? And again, you're talking about people who are walking around every day with careers and jobs and families, and it gets really kind of tricky because then they start to withdraw from public eating or public drinking. They're not going out to restaurants. Yeah. They're not necessarily enjoying family events and things like that they would have done before. So I think that's a really great point to make about it.
I love you saying that too, because I think when we think about functional dysphagia, and I can definitely say that I was guilty of this, it was a hard transition from a lot of the patients that I've worked with where I'm giving them 5 cc's of thin liquids, they're grossly aspirating, and nothing I do, say, or try can get it done safely, and they're desperate to eat or drink. And then the next person comes in and they feel like they can't eat or drink anything. But when we watch it, it's going down well. And so it can be hard to have the same level of empathy. But when you zoom out and you're saying, well, what am I doing as a speech language pathologist, and what's my purpose? And like, what am I trying to help, my patients with? And it's those things that you're describing. It's, liberation of their diet. It's their ability to like have a Thanksgiving meal with their family, and their ability to even go back to work. I have worked with plenty of patients, and like you said, young patients that are on FMLA because of this incident not being able to get back. A young man that was a cop and he hasn't been able to go back to work, and really wants to, but their fear and their anxiety around eating and drinking is so severe. And it takes more than just one swallow study where you say, well, look, it went down fine, so just go back to eating and drinking. And so it's a different type, or not, it's not a different type of empathy, but it's a different lens of empathy. And really it can still be so rewarding when, at the end of the day, their eat 10 reduces and they're back to eating their regular foods, they're getting back to work. And so it can be so rewarding and really successful too. So that's why I encourage people to get into it.
Well, and I think, you mentioned the fear and the anxiety, and we know that a lot of times what we see across the board with our dysphagia patients is that they're at a higher risk for depression. And so that I think that's a big component too, because if you're withdrawing from social activities that are familiar and fun, and now you're kind of being solitary and alone, and now you've got this fear and this anxiety, it sort of rolls into this whole big ball of potential psychological component too being a part of this.
Yeah.
And we kind of we didn't touch on it on here, but we were talking about the old, which is, it's not old. I think old in my mind of like older terminology of having this umbrella of conversion disorder.
Right.
And so can you talk about that a little bit?
Yeah. I love the history and the evolution of how we've gotten to functional disorders is really fascinating. So we think of conversion disorder, but if we take a step even further back before conversion disorder, it was hysteria. So until the 20th century, patients were considered hysterical. And if you look up, what is hysteria, or like, where does that come from? It actually means like the womb. And so it means that you have a wandering womb. And so there's used to be this concept that you were a woman who was who wasn't pregnant pretty much, or wasn't like producing babies, then your body was angry at itself, and the womb was wandering and causing, I'm not like the Rainer et al. 2021. I love it. It goes into all of this, all of the different supernatural and pseudo psychological reasons why we used to think that these people had these functional disorders. And so like the womb was going around and it's in your throat. And so like you need to go have some babies. So it wasn't until the 20th century that we got away from hysteria and saying like, oh, well, you're just literally just saying you're hysterical. And then it got into the conversion disorder, like psychosomatic, starting to kind of understand that there was this mind connection, and starting to see. And again, that article does a really nice job historically looking at how, scientists started to look at these patients and saying, hey, like many of these patients that have these disorders that we cannot explain actually have had many traumas, right? And now 2022 is officially when the DSM-5 by the American Psychiatric Association, the APA, officially said, no, let's call this functional neurological disorders. And that's where we now, yes, like the psychological component is important, but there's also this neurocircuitry component that is at play too. So FND, functional neurological disorder, is, per the research, a more preferred term by patients. It's really describing the delicacies of this diagnosis, the sensitivity and our still lack of full understanding of the disorder. And they really say that it's this combination of where neurology and psychiatry come together. And so as we think of functional neurological disorder, that as a preferred term when we're in the psychiatry literature, then we're really like not just looking at the fact that the patient has the psychological component, and that's where you get into like the biopsychosocial model, which I think is fascinating. But you also can say, hey, if we actually hook you up, a patient with a functional dysphagia, if I hook you up to an fMRI machine and I compare you to control subjects, your brain is going to light up differently. No, there's not a tumor. No, there's not a stroke, but the way that your brain is firing when it relates to swallow is different. And that's very different than like conversion. Oh, this is malingering. You're just stressed out. It's like, no, because of all of those things, now my brain is functioning, like is misfiring. And that's when they talk about like the hardware versus the software component. So that's where we're at now technically, but that's where I know I started the podcast by saying like it depends on who you ask, but if you're in the psychology world, FND with swallowing symptoms is kind of where the preferred area is.
Well, and one of the things I talked to Renee about was a patient that I had she had a lot of concomitant behaviors that was very interesting, and she was very young, but she'd also had, I think it was 4 concussions within the span of like 5 years. And the one thing that I remember her saying is that I was the first person other than her psychiatrist who she felt like she could come in and tell me how this was impacting her life and how she was truly feeling, and that I didn't place judgment on her, that I just kind of gave her that safe space. And so that's a place when I think you're talking about a different kind of empathy. Sometimes we're humans and we can be judgmental at times too, because we're human and we have to take ourselves out of it and think about how that feels to the patient, because they're there because something is not working properly, and it is impactful for their quality of life and their personal relationships and their ability to work and live and be happy. So I think it is good to give them a safe space to be able to figure it out.
And I think the scientific, looking at it in some of those lenses helps me at least add that real scientific basis to it, so that when you describe that case, I immediately am going, biopsychosocial model, that she has a biological predisposition. She has these concussions, right? So the concussions don't make her an exclusionary component where it's like, oh, she must have a structural problem. It's like, no, she had these concussions. And so that there's this biological disposition to it happening. And then who knows what triggered it? It could have been just one quick choking event, or witnessing somebody choking, or a big social life change. And the combination of those 3 things all got her to that place. And again, it wasn't chosen. I don't think any of us, I think it's so important. If anybody's ever had any sort of physiologic reaction to something that doesn't show up on a test. And I always kind of say with like stress, I get reflux. Like I'm, of course, being extremely pregnant, I get even more reflux. But if you do a test on me, my reflux is totally normal. But
Mhm.
you can't tell me that I actually don't have reflux. If I get really stressed out, I promise you there's acid coming up into my throat. But I've had an EGD done before and it's totally normal. So or people like and if anybody does public speaking, and for me I get super dry mouth, right? So I've been drinking water this entire time, and I know other people that get like lower GI issues. They don't have a lower GI problem, but that's the way that their body is reacting to this event. And so it's so important if you can like think of something that your body is doing, your heart rate is racing, but you don't have a cardiac problem, you can definitely empathize with these people or these patients, these individuals much more.
Oh, yeah. And I think all of us have probably experienced that, especially those of us that had the pleasure of working in acute care during the pandemic, because I
Yeah.
mean, it changed everything about like, I'm still not, I mean, I still react to certain things in a strange
Yeah.
way that I wouldn't have done 5 years ago. So I think, if you throw in all these other psychosocial things, certainly trauma being involved, certainly the fact that we know with multiple concussions that even if the patient isn't presenting with like a true post-concussion symptom, those neurotransmitters change the way that they distribute information. And,
Yeah.
that muscle tension piece, I kind of wanted to fly back into that. The muscle tension dysphagia piece sort of becomes, it's almost like a whole body tension.
Yeah.
And then it sort of sits right there in the middle. And it's
Yeah.
hard and I find I sometimes when I wake up in the morning and I'm thinking, do I want to get up yet? It's, like on a weekend if I don't have to be up early,
Hmm.
and I'm laying there and I find myself like feeling like, oh, you need to take a deep breath, girl, and let those
Hmm.
shoulders down. So I think, again, we
Yeah.
all sort of have these times when we do that. So if you can imagine that your life is like that every single day and
Yeah.
you're not able to really control it or alleviate it's very, very disheartening.
Yeah. And exactly. I think it's you're explaining that where you woke up and you felt that, and you immediately, as a speech pathologist, you were like, okay, what techniques do I need to do to like, dysregulate? I'm gonna, do some arousal modification on myself. But let's say that you don't have the tools to do that. I think we take so much for granted, the tools that are so like second nature to us. I don't work with kids anymore, but I haven't since grad school, but I have a daughter who's 3.5. And, the way I talk to her is the way that like was ingrained in me as a speech pathologist. Right. And so we have the tools to kind of dysregulate ourselves. If we didn't have the tools to dysregulate ourselves, then that would all of a sudden become how you wake up every single morning.
Hmm.
And that will turn into not, now you have significant neck pain and shoulder pain. And so then you start walking around and you're not moving around very much. And then, you're holding your breath all the time. Well, if you're holding your breath all the time, and then when you take a big breath, then you kind of choke it on your saliva, then you start coughing all the time, and then every time you take so it's so easy for it to turn into any sort of behavior. Again, we are behavioral therapists, right? And so we all know that there's bad habits that we wish we could kick, but yeah, good thing that you were able to dysregulate yourself.
I work on that a lot because what is self-care really? That's what I told my students this morning. I was like, what really is self-care? I don't, I think that's specific to every person because what some
Yeah.
people may find relaxing, other people don't. But, let's talk a little bit about the potential that there could be subtypes of functional
Yeah.
dysphagia.
Yeah. We've talked about Rome criteria is, kind of the gastroenterology description of, dysphagia. That's the GI esophageal. They now also call it kind of disorders of gut brain interaction. Then you have psychology that call it like functional neurological disorder with swelling symptoms. If you are in an ENT clinic, not a GI clinic, then that's when most of the time we're going to hear that muscle tension dysphagia. And I think that that's when a lot of like voice therapists or upper airway therapists are working a lot with dysphagia. We see that often. And I think being someone that also works with upper airway and some voice, I absolutely see that that happens. And so muscle tension dysphagia is like the most common of the kind of subtypes that I would say speech pathologists hear about, is really a subtype. And if you look back at Christina Kong's work, it's kind of hidden right there in the introduction where she says, I propose that muscle tension dysphagia is a subtype of functional dysphagia. And so that just means that there is this, the underlying cause is muscle tension. There's a couple of others that I consider. Phagophobia, I don't see as often or use as often, but that's still a term that's out there. And it's fear of swallowing. And so if you really think of muscle tension dysphagia, and then you're thinking about phagophobia, very different, right? Like somebody with muscle tension dysphagia could be very uncomfortable eating and drinking, but they're not afraid to, right? And within phagophobia now, I kind of more often start to see or think about ARFID, or avoidant restrictive food intake disorder. And I think that if you're a pediatric speech pathologist, you're like, oh, I know what that is. If you're an adult one, you probably are like, I'm not sure if I've heard that before. Because in the pediatric world, there's a ton of literature there. But ARFID is, this type of functional dysphagia, if you will, where avoidant restrictive food intake disorder, meaning you are avoiding eating for some reason. There's different types. The type that I work, so there's different types, like I don't like the texture, I don't like purple foods. The type I work with are I'm afraid of choking. I also will work with I'm afraid that eating is going to make my stomach upset. So they avoid eating because they're afraid of a consequence of eating, and that consequence has probably happened. And so that's where a patient might have one choking episode, and then they stop eating and drinking, solid foods for a month. And then that was a one-off fluke situation, but now they've avoided it so much that their anxiety level is through the roof to be able to do it again. And I always like Thomas and Eddie, there's a great PDF on it, Thomas and Eddie 2019. If you just Google it, it like is a great workbook on it. But they have this beautiful chart that they kind of describe that is the longer you avoid eating, the more anxious you're going to get whenever you go to start trying to eat again. And they describe it like as if, again, I always kind of talk about public speaking, but if you had a really bad experience public speaking and then you avoid it for a really long time, the next time you go to do it, your anxiety about it is even worse. And so you kind of have to like work your way through that. And so it's really, really uncomfortable. But being aware of that and knowing about that makes such a big difference in your ability to work with the patients, because you're like, hey, we're going to take a bite of something you haven't taken a bite of in 3 months. It's going to suck. You're going to hate it. It's going to feel really bad. Sit with me. If you let them take that first bite and then move on and like let it be crappy, then they'll never get past it. But usually if you can get over that first or second bite, then the rest they're like, oh, this isn't so bad. But there's so much anxiety. So anyway, there's a whole long rant to go on. ARFID is the other one that I would say that has such great literature and really has helped shape the way that I think about functional dysphagia. Although, just as like an aside, really ARFID is like a diagnosis that comes from psychiatry, psychology physicians. And so as much as I can say, this seems like ARFID, it's not something that I don't use that diagnosis because it's not one within speech pathology technically. Right.
Well, and the interesting thing about that is many years ago, my son I guess he was in middle school, and he wanted to take Lent seriously and give up something. And so he asked me if I would do it with him. So we both gave up meat. So I have not been someone who typically eats beef or pork for, oh gosh, it's been like 15 years, I think now. But what I find is that when you, like you said, even to me, I feel like I'm normal-ish, whatever normal is. My swallow is functional, let's say that. But when I have to be careful because I haven't eaten that. So my body is like real confused if I accidentally get something like that. And I know because we ordered takeout, this has probably been like a year and a half ago. and I ordered a sandwich that was not supposed to have beef. And I got it, I saw it, I smelled it, and I knew it was not what I ordered. And my husband's like, "Oh, you're fine. It's just they just cooked it too long." And I'm like, "That's not right." And I took a bite and I was like, "Oh no, nope, not happening." And again, so if it's something like that, and I don't have a fear or anxiety, but it also, I know that my body is going to go, "Oh girl, I don't know what you were thinking." And so if I did have a true disorder, then I think that it could have been a lot worse.
That
Um,
I feel the same way about meat because I now eat some chicken. But I was a vegetarian for 10 years. And my husband, I married a Texan, poor thing, like wants to smoke meat and I won't eat it. It's a point of contention, trust me. But,
I know.
and so he loves all that type of meat. And like even me, I have my memory of like eating an Impossible burger. Like I like Beyond Burgers, this would be good. But I remember eating an Impossible burger and I was like, "Yep, you're right. Like this seems like it's like meat." And I'm like, ooh, like it just like the texture, the feel, like all of it. I couldn't, like my mind couldn't get past it. Like that I was just like, this feels wrong and weird because
Mhm.
it's been 10 plus years since I've had a texture like this. And so my body and my mind is just not used to this. Yeah, I haven't really thought about it from that perspective, but it's, you're fine. You're not gonna choke and like eating it isn't gonna kill you, but the way that your body and your mind is probably reacting, it seems like it is. And so again, these are like small real life examples of what this could feel like.
Yeah, exactly. Because I think it helps you understand when we can give a real life scenario of something like that, how in an isolated moment, I was like, "Oh no, absolutely not.
Yeah.
Nope, nope." But
And
if you
and I
have a
think
bunch of other symptoms going on and stuff going on, of course you're going to be like, "Absolutely not."
Yeah, and I think that's where I so commend pediatric speech pathologists that work with kiddos with the texture-based ones, because
Mhm,
I really have not been able to master that in the adult world. If you're afraid to eat it, I can, not convince you, but we can work together to make it safe, with repetition and, working up a hierarchy with small amounts and really like giving you more and more experiences that it's positive. I can work
mhm.
with that. I find it fascinating and absolutely such something I really want to applaud, the ability to work with somebody to say like, if they were like, "Oh, okay, but it's fine, like yes it feels weird but just like take another bite," and it's like, "No, I don't like it, like I don't like how it feels, I don't like how it tastes," like, and for a lot of those like texture based like RFID ones, I feel like that's what it is. And I've had a few like kind of functional dysphagia cases, and whenever they kind of go into that realm where they're like, "Yeah, but it doesn't feel right," I don't have a good argument against it because I
Mhm.
can't say, "Oh, well, it should." Like most of the time, I mean, I definitely have a lot where it's like, "Oh, it feels like it's stuck," or it feels like it's going down slowly. And we work through that and say, "That's okay. Like, let's breathe through it. Let's let it pass." Like, just because you have that sensation does not mean that it's a bad sensation. And like, that's when you get into like hypersensitivity and hypervigilance, which is so important in the functional disorders realm, is that these patients have such hypersensitivity and like the neurocircuitry can explain some of it, and they have such hypervigilance, and like that cycle is what makes the functional dysphagia worse and continue. So hypersensitivity being that I have this increased sensation, but it's either normal or it's not there. And hypervigilance is I'm so hyper focused on it that sensation, like it becomes bigger and bigger in my mind. And I usually say it's like getting pinched. Like, yes, okay, I pinch you and then I let go, but how quickly can that sensation, like it doesn't go away right away. And so when you swallow, you can get these sensations, but like you just have to kind of let them pass. I don't know. Yeah.
Well, it's interesting too, because I think really most people can probably relate to a time when they were eating rapidly, or maybe they weren't, and they had something go, as my grandmother would say, in the wrong pipe, or go the
Yep.
wrong way. We hear that a lot, go the wrong way. Or they'll straight up tell you, "Well, oh, I know I aspirated." And you're like, "But maybe you didn't." But you have to sort of develop this this vocabulary and language that is more empathetic, because you don't want to put them off so that they don't want to come back. Because again, at this point, you might be the fifth stop on the road for them, and they're really trying to find someone who can just help them, which moves us into the world of treatment for functional dysphagia. So let's jump into that and like kind of what you do.
Yeah. So one, I highly, highly recommend Baker et al. 2021 has a great, article that describes functional disorders in the speech pathology world. So functional speech disorders, functional cognitive disorders, functional swallowing disorders. And they have a lot of really great kind of quotes or scripts to use, because the most important thing in functional dysphagia therapy is the education and counseling component. And so learning your verbiage and how you tell somebody. And I definitely have like different ones that I'll use depending on the patient. So you may use that, you have a software problem, not a hardware problem, which is, for anyone that's not super techie, like I'm not super techie, the computer's fine, the mouse is fine, the keyboard's fine. That's your hardware, issue. So all the hardware is working fine, but the software, every time you open Microsoft Office, it's like, giving you this error message, so education and counseling, learning a good way to really tell them that I believe you, this is real, this is what it's called. These are some theories that may have developed, to kind of get us there, but we don't really fully understand. But I do believe with what you're feeling, and we need to, just like you developed these maladaptive behaviors, obviously behaviors that are not serving you, that are not making you feel good, we can undo them, we can unravel them. And we're going to do that together. So number one is absolutely education and counseling. Number two is arousal modification. And so that's term from the gastropsychology literature, or like psychology literature, teaching them diaphragmatic breathing, teaching them some like head and neck stretches, anything to kind of reduce any of those, like, if they're coming in like this, let's like learn to bring it down. Let's learn the diaphragmatic breathing so that way, when they do have that moment, they're trying a food for the first time, they know how to regulate themselves. Like that tool that we were talking about before, how to regulate or dysregulate yourself. They need to learn how to dysregulate themselves so that they don't, they start to feel themselves getting to a 5, 6, 7, and they just keep pushing themselves. And I'll see that a lot, especially in my young patients that are like in their 20s. They're just like, I don't want this to happen, so I'm just going to like pummel my way through it. Like these are hardworking individuals, but they're trying to like beat their way out of it, right? Like, and instead it's like, no, I need you to stop. You feel bad. Let's stop what we're doing. Let's dysregulate. Let's breathe. Let that sensation feel better. And let's take another bite. Yes, I know this is taking a really long time, but if we can kind of keep learning this, it'll go quicker. So education and counseling, arousal modification with really big emphasis on diaphragmatic breathing. And then the last piece is really like this food hierarchy training with biofeedback, if you have it. And I always say, like, we've got the bells and whistles at the Swallowing Center, but that doesn't make a good therapist. It just means I have some fun tools that I can use. So if you have something like surface electromyography, that's great. I don't even use it all the time. A mirror is awesome. But all those bad maladaptive behaviors that you've seen, you address them head on, and you're like, okay, so yeah, we need to keep our head neutral when we swallow. And you work your way up with easy foods and then work your way up to the harder foods. And that's where that RFID literature can be really helpful. Thomas and Eddy, 2019, they talk about putting it in a thermostat. And so one of the first therapies I'll do is I'll say, okay, let's talk about food, and, water's at a 0. Great. Where's something like a banana? All right, that's a 60 out of 100. Okay. Where's like applesauce? Okay, it's a 20. Great. Where's grilled cheese sandwich? And like putting them in order so that way, everybody's a little bit different. They've had different experiences with different types of food, but you can work your way up that hierarchy together, work on stopping all those maladaptive behaviors. But that's once you have that education counseling, learn those tools to dysregulate, and then eat, right? And like work through that hierarchy, and give them pauses. Sometimes that might mean I'll share a case study often where the first like 2-3 therapies, we only did liquids, and it was like liquids through a spoon, then it was liquids from a cup. Then we did like applesauce, and then we did pudding, and then, so every session, and it was just like, as long as we were kind of moving forward and like kind of keeping the momentum going.
Have you done anything with any kind of manual therapy for this?
No, that's a great question. So especially when you look at the muscle tension dysphagia literature, they talk about voice therapy. They've, so some of that like SVOT, semi-vocal cord, cold. No, there's the end of the day. Like the cup bubbles and things like that, that forward tone focus, anything to unload the tension in the back of the throat, circumlaryngeal massage. I'm not trained in manual therapy. Obviously, it's a great technique. So that would be especially for those patients that have a lot of the muscle tension component. That I personally like more of the stretches, massages than doing the voice therapy, unless they have a voice problem too. But there is good literature to support that doing some of those like laryngeal tension reduction techniques of like forward tone focus can help too.
Yeah, I am trained in manual therapy, and I actually had Walt Fritz on the podcast earlier this year, and I was, and he, I'm sure he's heard me say this. I was a little like, what is this manual therapy? This is not what speech language. We don't touch people like that. That's not what we do. And so I was a little like nervous about the course, and it's not like I'm brand new. I've been around for a little bit now, but I really, really learned a lot there again about that psychosocial aspect, that empathetic moment of not leading the patient to the answer, but like helping them help you, if that makes sense. Like I'm asking questions like, how do you feel? If I manipulate anything, is this different?
Yeah.
How does it feel now? Does it feel good? Is it okay if I hang out? And it really becomes more of this true shared decision model, but also this patient-centered, where you're really including them in what you're doing. Because if it's really, I did this with one of the 20-year-old patients, and the first thing she said, I explained everything. She had the mirror in front of her. I just kind of hung out on the top of her shoulders for a bit. She was fine. As soon as I got close to her neck, she was like, stop.
Yep.
And I was like, okay, and you don't have to tell me anything else other than stop. And often what I'll find is a lot of people do want to tell you. And I'm like, but I explained to them at the beginning, if at any point you're uncomfortable, or you don't even have to be uncomfortable, you just want me to stop, tell me to stop, and I'm not going to ask you anything else. If you want to share, that's fine, but I'm not going to push you. And so a lot of times I find that what would happen is they would want to try to tell me so that they could better understand their reaction. That was one thing. And then the other piece of that is, again, going back to that trauma-informed care and understanding that a lot of the reaction is based in trauma. I think what our traditional thought of trauma is, it's sort of twofold, really. If you're not trauma trained, you think it's either trauma, the traditional sense of like a car accident, or you witnessed something, or you had some sort of abusive incident, or you witnessed an abusive incident. And it can be all of those things or none of those things. Again, going back to the pandemic, I think a lot of us SLPs and other healthcare workers, we definitely have new trauma that's changed the way we practice, but our life. Like I said, I still have reactions to really weird stuff that I shouldn't have reactions to, but I do. But again, if you take yourself out of it as a professional, and now you've had this experience, but what is your patient experiencing, and how do you change your perception of it?
Yeah, I think that psychological or psychosocial component, trying to tease some of that out or understand it can be really important. Still knowing though, I mean, if you look at some of the functional dysphagia literature, it could be 50-50. So I think it's important to know that somebody can come in and not have, anxiety, depression, comorbidities like that. And 50% of the time they can. And I definitely, at least in my experience, there is something, associated that may not be the cause, but may be what's precipitating or perpetuating it, right? That the cause is something different, but there, these psychosocial pieces. When you were describing your patient when doing manual and touching their neck, it reminded me of, I'll use like fees specifically as like a biofeedback. And so as they're eating and drinking, because I mean, I love using MBS as a biofeedback because we do it and we'll show them and they can see it. But of course, I'm not going to keep radiating them to show them every time we try. But I can throw a scope down while they're eating and they grab their throat and they can say, oh, it's stuck. And we can kind of look and say, I know it feels like that. I know that's true. I know that's valid. I know that that is what you are feeling, but I want you to look while we're here and see you have a beautiful airway. It is like very well protected. Those pockets are empty. And so I want you to try and breathe through that sensation. When I did it for one of my patients, we'll still like do a quick strobe beforehand, kind of taking a look at things. So we had the collar to put around. She immediately broke down and started crying. And then it was like, oh, and then like got into an abusive relationship that she had in her 20s that choked her and like all of these things. And it really elucidated a lot. I was like, oh, that can explain a lot. And that was also a moment for me that said, okay, have you know, I think what we're doing is really important, but also it sounds like we have some of this trauma that we need to unpack. Are you seeing a counselor or have you been seeing a counselor? And then that's when we circle that back around. And I will say, especially lately, I feel like a lot of the cases that I have, I'm so happy to work with them, but I can't unless they also have like some level of counseling that they're working with, because I scratch the surface, right? Like we're not digging in to the things that are making you so sensitive to your neck from 30 years ago. We're kind of dysregulating those sensations, but it can be so important. And I've only been able to connect with like one counselor in the past and like kind of align what we're doing. But if you can, it's so helpful because, you know, we have to do the counseling component, but we have a limit.
Right. Yeah. And what our scope is, like you mentioned, doesn't cross over into like certain realms. And certainly it's not appropriate for us to sit there and try to give strategies for managing their stress and anxiety related to the trauma if it's not relevant to the functional dysphagia. And I think that's an important distinction to make, because ethically we can't cross that line and we need to refer to the appropriate people who are trained for that.
I had a patient I just recently reached the discharge to, and it was a really hard discharge because of course we established this really strong rapport and we're doing really great. And at the very end, this was one that I shared with one of my fabulous graduate students, and she really took the lead on it. And at the very end, we're sitting there and we said, hey, look, your Eat 10, you know, it went down significantly. You have no food avoidances and you started to eat at restaurants again. Like, this is fabulous. These were our goals. And she's like, but I still don't feel great. I still, you know, and her husband's like, the only thing we do is go to these appointments and go to the grocery store and like, And we had a very like strong heart to heart where I said, you know, from our swallowing problem, that is my role. And you have made such amazing, you know, progress with that. What you're describing is different. And I was like, and it sounds like, and we kind of like, I always like try to pull back any kind of diagnosis that you had. Have you been diagnosed with depression before? This sounds like it may be depression again. This sounds like something that you need to work with a counselor for. I love working with you, but that's a component. Like, we no longer have goals for swallowing. We've reached those goals. These other goals, you know, need to be with somebody else.
Yeah. And I think I'm the same way. That one young lady that came to me already had a counselor, which was helpful, because I think unlocking some of the pieces that she had for her voice and for her swallowing were impactful on her therapy there, because it gave her sort of that freedom to figure out, okay, what thing do I need to be telling my counselor or working through? Yeah. And it really, she wound up, I mean, at least when I discharged her, she had the same thing. She had pretty much met her goals. She wasn't having the same experiences. And she was someone who she had a lot of migraines. I remember her coming in and talking about that a lot, that were very debilitating and limited her, not just psychosocial, but just her life. You know, she wouldn't leave the dark room. Sometimes she would sleep for 2 days because that was the only thing that alleviated that. And again, that's not my scope. That's okay, you need to go back to your neuropsychologist because she was seeing a neuropsych for the original diagnosis of functional neurological disorder. And then she had the counselor also. So she was doing everything correctly before she got to me. So it made my job, even though her case wasn't easy, it made my job easier because I didn't have to keep referring her out to someone else.
Yeah.
So
I think it, and on the vice versa, I think though, exactly like you're saying, but you had a role there. And so as much as like we just talked about all the examples of when, hey, we need counseling to help us out, I think when there are these very specific behaviors related to swallowing that we can recognize that are abnormal, we are looking at the swallow and we are looking at these inefficient movements, and we know how swallowing is supposed to work. So we are the best to really be able to, identify those behaviors that we need to like address and work through. And I think a psychologist, and there may be few that can also do that, but I think a psychologist can teach them, and they have like great work on like cognitive behavioral therapy. They do hypnosis, they do eye movement desensitization, reprocessing therapy. There's repetitive transcranial magnetic stimulus. There's so many other things that other, the psychologists and neurologists and so forth can do. But I think it really is within the speech pathologist role to do this. And I think seeing a counselor, learning some of those dysregulation, techniques and tools, but they have to like sit down and actually swallow. And you're not going to do that in a counseling session. I've gone through plenty of counseling, and we don't like, or I don't know, maybe they would, but really it's us that are going to go, okay, now swallow. Like, let's swallow. Your problem is swallowing, so let's do it. Let's not just talk about it.
And it's just really interesting that you brought up ARFID a couple of times, and I certainly had heard of that before, and sort of that, why did anybody think that before? Because, we know this with kids with pediatric feeding disorders, that they have different components when it comes to sensation and texture and color. And why would that not be relevant to an adult? With or without a neurological disorder or diagnosis, right? It makes perfect sense, because if you have a negative experience that changes the way that your brain is processing things, of course you're going to have a different reaction. And if that keeps going and going and going, again, we touched on that at the beginning, but I find it really fascinating and interesting. So
absolutely. I think again, that's why it's so great to learn from each other. I definitely learned from some speech pathologists that specialize in ARFID, so that pediatric specialty, and like drawing on that to apply in the adult world, because absolutely. And they've had really good, as like an aside, as you get into the adult world, they definitely will talk about eating disorder, because if you think of like, oh, I'm not eating, of course, we'll work with a lot of young females, and eating disorders can absolutely be in the patient's history. It's often quite common, and that's a whole other talk on like gastroparesis and like how that can all impact somebody. But there's plenty of studies that show like ARFID is different. Like their avoidance has nothing to do with their body image, and they're not avoiding food because they're afraid of like it becoming fat or that type of preoccupation. It's a very different reason for avoiding food.
Yeah. Well, Jaimie, this was fascinating, and I really appreciate you coming on and sharing your knowledge and expertise. I was really excited about this one because, again, I just think it's so different and not something that a lot of speech language pathologists are well versed in. And the studies that you have provided, I'm going to give to Speech Therapy PD to put in the notes for the show. So for you all that are joining us, we'll have the resources up on the website so that you can take a look at those studies. But yeah, thank you. Thank you so much. And hopefully everything goes smoothly in the next couple of weeks. I appreciate you being on here at your stage right now.
Yeah, 37 and a half weeks pregnant, so I sounded breathless. I apologize.
No, you were fantastic. You were fantastic.
Yeah, so definitely, look at the references. 100%. If you just need somewhere to start, that Baker et al. Article is golden. 2021. I'm not an author on it, and it is print, and you can like just step right into the functional world. It's really great.
Yeah. Thank you again, Jaimie, and great to see you. Hopefully we'll see you again.
Yeah, thank you. Bye.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with Brainstorms 20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms 20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.